Thank you everyone for joining us today. So as you'll see on the slides here, we've just taken this opportunity to bring back some of the experiences from POC25 conference that was held in Bangkok. So we'll be giving the opportunity for some of the early mid-career researchers that were lucky enough to be scholarship recipients as well to share their experiences. So I'm Tanya Applegate, and I work here at the Kirby Institute, and Jessica Michaels, also Deputy CEO of ASHM. And so just recognising we have people online joining us and also in the room. But before we get started, I'd very much like to acknowledge the traditional custodians of the lands that we are meeting from here today at the Kirby Institute, which is the land of the Bidjigal people of the Eora Nation, and pay my respects to their elders past and present. So just briefly, actually, I think we do have, just before we get into the session, the format is that we'll have a brief introduction of RAPID, which is a Centre for Research Excellence, and we'll speak to the POC25 conference. Jessica will briefly describe that, and we'll then hand over to our 5 rapid fire speakers who will each bring their own perspectives, and Jessica will introduce our speakers at the time. We do have 2 online and 3 in the room today. So just briefly, to provide a very brief background as to how this conference came about, it was sort of a child born from RAPID, which is the Point of Care Research Consortium for Infectious Disease in the Asia Pacific. And that's a Centre for Research Excellence funded by the National Health and Medical Research Council and led by Rebecca Guy, who's here with us today in the room as the PI. And essentially, it's a very broad, it's an amazing group of people that were all brought together across the Asia Pacific, who are all in their own ways invested in scaling up point of care testing for infectious disease. So the goal of this research consortium was to bring together all of our experiences to take us out of the silos, whether it might be from the different communities we're working with in country, or it might be the different infectious disease that we might be focusing on, and to share all of the different disciplines that we collectively have to try and elevate and accelerate the scaling up of point of care testing. So specifically, we do have a broad range of disciplines. You can see them here on the right with epidemiology, health economics modelling, social science, clinical science, and lab science. And we do have a very strong network of in-country implementers working very closely with the ministries of health and community organisations, and also in partnership with a large number of global partners as well, to make sure that whatever we are doing here is in context of being able to scale up globally. So just briefly, the point of care testing, building the framework that we lend our work to is very much focusing on the health systems building blocks that are here. And you can see that what we are doing is overlaying the research framework that builds in the clinical science, the social science, the health service interventions, modelling health economic analysis to make sure that we're generating all the evidence that's needed to help inform how we can best scale up point of care testing for infectious disease across these different infections. So there's one thing that's really important to emphasize, that it's no matter what our expertise is and our experiences are, the whole team are collectively united in this efforts to celebrate the community strengths, which is how these programs are very much enabled and driven by. And I think that came out in the Point of Care conference that we'll be speaking about shortly, as to the core themes of the conference itself really reflected that all of this work is underpinned by the strengths of the communities delivering these services themselves. So just to start with, POC23 was the first conference we held here in Sydney, and the feedback we got from that was really energizing, and people really appreciated that it's a smaller conference, but what it enables is people to have that conversation with people that are outside their infectious disease or outside their disciplines, because often we go to an HIV conference, or recognising there's the Australian Viral Hep conference on at the moment, which many people at the Kirby will be attending. And so it's being able to learn from across those boundaries and silos that people really valued. So we held this next one in Bangkok in POC25. It did take 2 years to put together. So I'm actually going to hand over to Jessica to briefly introduce POC25.
Hi, everyone. It's so wonderful to be here. Thank you for the invitation to co-chair with Tanya. As Tanya mentioned, we ran POC25 in Thailand in June recently. And while it did take 2 years to come together and we had, many barriers, including volcanoes and major global policy shifts, we did get there in the end. And we were so sort of pleased that we were able to make it happen. And I have to mention Dr. Nataya and Dr. Rosa Fawn, who were really instrumental in helping us make it happen. We had 280 registrations, 58 posters, 150 abstracts, and 122 scholarships. And the scholarship recipients were from over 13 countries and regions in Thailand as well. And we had well over 15 countries represented at the conference in general. So it was really, really fantastic. I think I won't obviously go into all of the names here, but I especially just want to mention RAPID as a major sponsor and thank Rebecca Guy for their support. We really couldn't have made the conference happen without RAPID's efforts. And it was just really fantastic. We also, of course, had wonderful support from industry as well. We had global endorsing partners, which really gave a lot of strength to the conference. The conference is a new conference, and it was really important for us to make sure that we had sort of some real kind of gumption behind it, and we had some really key organizations backing it with us. We had scholarships, as we've already mentioned, from RAPID, ASHM, Pathology Technology Australia, and NRL as well. And we had some great exhibitors as well, which always makes it, really fun in a conference environment to have that engagement. So we said 2 years of dedication from the conference exec committee. And as I did at the conference, I will once again embarrass Tanya and thank her for her contributions. She really was unbelievable and just put in the most absurd amount of hours and dedication and love into this. And it was extremely meaningful and very much appreciated. So thank you. And I'm sorry to have embarrassed you again. So overall, across the 3 days, we had over 22 hours of content. We had 150 abstracts, 44 oral presentations, 58 posters, 46 presenters, and 32 chairpersons. As Tanya mentioned, we had a lot of key themes that came up, I think definitely, and this was something which was really, really loud and clear in the 23 conference, was around the barriers and opportunities of enabling policy environment and regulatory environments and just how key and critical that is. And it's something which is, I think probably one of the biggest barriers in this space. Again, and obviously this was very sort of pertinent given the changes in global funding around securing funding, having sustainable funding and programming, and how we make sure that we are doing that and we're not relying on external funding sources. How important it is to have integrated services that benefit the community and the health systems as well. And I think we certainly heard that the pipeline is exciting. How do we get people on board? How do we bring people along on that journey? And that obviously speaks back to the importance of enabling and regulatory environments. And of course, again, centering community in everything that we do and just how critical that is. Definitely, I think having such a great sort of array of people joining us, obviously from many, many countries, but also speaking about many disease areas, hearing about malaria, hearing about TB and what's happening in those spaces. It's really, really fantastic. Having a really sort of varied sort of cultural lens as well put onto the conference and the presentation was really fantastic. And as we mentioned, and as we'll hear today, having lots of early and mid-career professionals taking part, and a big thanks to Lise Lafferty for driving that work. In terms of what's next, while we haven't landed on the next POC, 26, 27, we're not sure yet. We have obviously been thinking about what do we need to do to keep moving forward, and obviously thinking very much about, the sort of fundamental core principles of RAPID and their goals, and of course goals of organizations like ASHM too. So, interactive workshops, how do we engage industry? How do we have those conversations? How do we engage government? How do we make sure that we have a fantastic reach? And how do we collaborate with other conversations, other forums, other meetings which are happening as well. So enough from me. We're now going to move on to our rapid fire presentations. So we're going to hear perspectives from 5 different presenters, and it is my pleasure to introduce Glen Duncan, who is a project officer in the First Nations Health Research Program from the Kirby Institute. Thank you, Glen.
Thanks very much for that introduction. So before I start, I would like to acknowledge the Bidjigal people that are the traditional custodians of the land on which we operate here at the Kirby, and I would also like to pay my respects to elders both past and present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people who are present here today. Just following on from that, at POC25, we were also able to have a little bit of a welcome, a little bit of an acknowledgement to the traditional owners of Bangkok and Thailand. So I do have it here and I will read it out. So we would like to acknowledge the diverse communities, including Mon and Thai ancestral groups who have lived on and cared for the land that is now Bangkok, where we all have the privilege to be meeting today. This is shared in the spirit of cultural respect and global solidarity, and in recognition of the histories and communities that continue to shape this place. So I just thought that was a really good, but also very inclusive way to open the conference. Again, it's always important to acknowledge the traditional owners of whatever lands you're meeting on. So, okay, so to start, we were able to run our session, which was titled "Geek Out on Point of Care." We thought that it was important to have this session on the first day, given how it was designed to be informal and that it would be the perfect icebreaker at the conference, as attendees had pretty much traveled all over the world to be there. It was a good way to ease into the conference as it allowed people to get acquainted with one another, and we feel that it was able to set the tone in terms of meeting and networking across the 3 days. The details, as mentioned on screen, we were able to hold the session on the Thursday, 19th of June, 2025 in the large hall that we had the opening and the closing for the conference. The chairs were my colleagues, Louise Lafferty, Stacey Foster-Rampant, and myself. Okay, and as far as acknowledgements, I would like to acknowledge my colleagues, Louise Lafferty, Stacey Foster-Rampant again, who co-facilitated the session, and the RAPID EMCR committee, Alison Marshall, Caroline Watts, Jackie Thomas, and Belinda Hengel, and the work that they have done. Okay, so to get into it, what is speed geeking? Speed geeking is inspired by speed dating. Speakers or geeks share their expertise with small groups of around 8 to 10 participants seated at different tables, and each speaker gives a 5-minute presentation or talk to their current table. So that's followed by 5 minutes of questions and discussion, and after 10 minutes, the speakers then rotate to the next table where the attendees all remain in place. This continues until each speaker has visited every table, and we found that speed geeking, it was set up to break down traditional power dynamics by fostering more interactive and conversational exchanges rather than one-way presentations. We also make it a priority to invite speakers from a range of different areas with careful consideration given to gender balance and speaker diversity. And prior to POC25, a speed geeking session was also held at POC23 in Sydney. And the sessions are purposely held on the first day of the conference and provide an ad hoc networking event where attendees at a table get to know each other throughout the duration of the session. All right, so presenters. In terms of our presenters, we were fortunate enough to have a range of professionals from various areas relating to point of care testing that were able to speak to their areas of expertise. And as noted on screen, we were able to have Mel Fernando, who is a senior research officer, who was a part of the Yandamanjang First Nations research program and the surveillance and evaluation research program here at the Kirby Institute. Mel has over 18 years of experience in Aboriginal and Torres Strait Islander communities, public health and local health districts. Her current role here at the Kirby Institute involves integrating Indigenous methodologies, cultural governance frameworks, and principles of data sovereignty all into programs and projects that she oversees. We also have Yama, who is a clinical pathologist specialist in Ahmad Diponegoro Hospital, West Borneo in Indonesia. She has a focus on infectious diseases, blood bank and transfusion medicine, immunohematology and oncology. and has conducted several researches in infectious diseases, blood bank and transfusion medicine, oncology, gastroenterohepatology, immunohematology, and neurological diseases. It's quite a mouthful. So we also have Sandra, who is a public health practitioner from East Noosa and is also currently a PhD student at the University of Melbourne. Sandra was able to speak to midwives' experiences on the HPV DNA piloting in the East Nusa Tenggara province and how midwives provide cervical cancer screenings in Eastern Indonesia. We were also fortunate enough to have Bev Lawton, who is the founder and director of the National Centre for Women's Health Research in Aotearoa at Victoria University of Wellington. Bev was also named New Zealander of the Year for 2025 for her extensive work in women's health and New Zealand's National Cervical Screening Program, which in 2023 introduced HPV cervical screening with self-testing. And yeah, we had a late pull out for one of our speakers, so we were very, very fortunate to have her come along. Mun, who many know at the Kirby, presented the talk From Lab to Community, Expanding HIV Testing Access Through Point of Care in Fiji. And we also had Mitchell Starr, who is a senior hospital scientist at St. Vincent's Centre for Applied Medical Research, working primarily in diagnostics from point of care testing technologies, self-collected sampling methods in HIV array research and development, who spoke to serological point of care devices for infectious diseases plus new collection devices. Okay, so to the second session that I will speak to, I was able to be a part of the Empowered Communities session, which was led by Tanya Slater and Bev Lawton. This was chaired by Bev and Professor James Ward from the Post Centre at the University of Queensland. So the photo that we have, that was taken on the first day of the conference. So it was a little bit of a welcome. We sort of had like a bit of a gathering. Everyone got to know each other just because over the first 2 days at least, we were doing a lot of work together and managed to say where we're from. It wasn't, I guess, like a welcome to the country, but it was kind of, we were getting to know each other, what lands we're from, them being from New Zealand, us being from Australia, and the work that we were doing. So I thought it was a very special moment, actually. It was very good to meet everyone. We corresponded for a couple of weeks, and just to sort of, put faces to names, it was a very special experience. Okay, so acknowledgements. I would like to acknowledge Tanya, who was able to put us in touch with Bev and Dr. Tanya Slater, who's a senior research fellow, and organised and facilitated the session, as well as my colleague Jade from the Kirby. Okay, so to start, we were able to have Bev and Charles, who was also a research fellow at the National Centre for Women's Health Research, to give an introduction. The chairs then spoke to the importance of Indigenous voices and leadership of point of care in communities. Having Indigenous leaders are empowered in healthcare as clinicians, advisors, and decision makers. We see stronger trust, better outcomes, and systems that truly reflect the needs of the people they serve. That was across the board. Through discussion, we would see that and we would see a lot of similarities between what's going on in New Zealand and different communities there to what's going on in communities here in Australia. For presentations, we were able to listen to a range of different presentations from wide range, such as introducing Indigenous health providers, community representatives, and researchers from different parts of New Zealand who have implemented and or are about to implement point of care testing, share learnings from previous studies, discuss different contexts for point of care testing, and highlight the importance of Indigenous people influencing policy for point of care testing in their communities. Jade and I were able to speak to the importance of Indigenous voices and leadership in Australia, and regarding Aboriginal and Torres Strait Islander communities in Australia and what it means to have elders at the forefront of community-led programs. As a part of SERP and RAT here at the Kirby, we have our First Nations point of care testing governance group that we have formed, and at the crux of that, we have Aboriginal and Torres Strait Islander voices, where we ensure that their voices are heard and are pivotal in the decisions that are made. And then following that, we had our panel discussion, which was followed by concluding remarks. And just to go into a little bit about the panel, so we had Charles, again, he's a research fellow, Vilma, who was a community support worker, Lisa, who was an associate professor at the National Centre for Women's Health, and Dr. Mathobi, who was a clinical microbiologist, as well as Jade and myself. Through the panel, with the questions that were asked, we were able to provide a perspective, I guess, about the communities here in Australia. Elders being at the forefront, as mentioned, just having elders at the forefront and just influencing, I guess, the next generation. You know, you have those people there where they're able to again influence the next generation on the decisions that they're making, encouragement, and we found that happened as well as New Zealand. So yeah, and that's pretty much it. Yes.
Thanks so much, Glenn. That was fantastic. I was lucky to stick my head into the speed geeking session at the conference, and there was such a good energy. Everyone was so engaged, but also having a great time, which is fantastic to see. My pleasure to introduce our next speaker, Dr. Louise Chow, who'll be presenting online. Louise is a Senior Research Officer in the Surveillance and Evaluation Research Program at the Kirby. Thanks, Louise.
Thank you. Okay, thanks for that introduction, and apologies, I'm unwell. I wish I could have been there today, and so please excuse my raspy voice. But I would just like to start by acknowledging the Gadigal people of the Eora Nation, the traditional custodians of the land where I'm joining from today, and pay my respects to elders both past and present. So I'm Louise Chow. My background is in molecular biology and diagnostics R&D, and I'm working in the SERP team where my position involves evaluating new diagnostics. So I was very excited to go to POC25 and hear about all the new tests in the point of care space. Harisha from FIND and Tanya gave really great presentations that gave an overview of the point of care testing landscape. And as you can see from these photos, and these are only single slides from their presentations, there are a lot of point of care tests available, each with their own unique features. However, throughout the conference, I saw some features of point of care tests come up again and again, and it got me thinking about what features would the ideal point of care test have? Or more like, what are all the point of care 25 attendees dreaming of when they think of the ideal point of care test? So today I'm going to step through some of the key features of point of care tests that came up again and again throughout the conference. So the first one I'd like to touch on is the ideal point of care test must be portable. So this is vital if trying to reach remote communities which don't have the resources for a permanent point of care facility, considering that traditional pathology testing is normally completed in laboratories with controlled conditions and large, delicate equipment. Translating this into equipment that's light enough and durable to essentially carry from site to site is quite difficult. And I'd like to touch on two presentations that highlighted the importance of portable point of care tests. The first was this fantastic presentation by Dr. Samantha Tinze, who is a doctor based in the Philippines and is working on bringing tuberculosis diagnostics to the remote islands of Cebu. They travel between the islands on boats, transporting equipment island to island. I got these photos from her website, which I've included the link at the bottom, and there's lots more amazing photos and videos on her website. So they use an ultra-portable chest X-ray for screening, and then they use the TrueNat MolBio molecular system to confirm tuberculosis and to also determine antibiotic resistance. So this system, it's a PCR-based system. It's battery and solar powered, portable. The reagents are stable at up to 30 degrees for up to 2 years, and we're looking at about a 1 hour sample to result time. And using this approach, they've gone from testing 200 patients per year prior to 2022 to almost 6,000 in 2024. And they can provide on-the-spot treatment for drug-susceptible TB or a referral for treatment for drug-resistant TB. The second presentation, I think most people will be familiar with it. It was a presentation by Dr. Paula Srupa, who presented on the amazing work being done in PNG for the testing and treatment of HPV using the GeneXpert, which is a fully automated PCR system. They fitted out an outreach truck, which is essentially a lab on wheels with its own generator, mini lab with the GeneXperts, and a bathroom for self-collected samples. And the test results are ready within 1 hour, and treatment can be administered on the same day. The next feature that I'd like to highlight is speed. So the ideal point of care test must be fast. First presentation I'd like to touch on was by Tristan Clark, who presented the results from the flu POC trial, which went from 2017 to 2019. And they tested patients presenting to the hospital with respiratory symptoms with either a point of care test or the standard lab-based test. And they used the BioFire film array, which is a PCR-based sample to result testing platform with huge multiplexing capacity. From one sample, they can test 22 targets with sample to result in about 45 minutes. And they found that patients receiving the point of care test received results within 1 hour compared to standard lab testing, which was about 24 hours. And this resulted in the patients tested with the point of care test receiving antiviral sooner, being appropriately isolated, and having improved clinical outcomes, including being less likely to go into the ICU. I would also just mention that in the time since their study, bioMérieux has released a new point of care test, the Spotfire, which tests for 15 targets in 15 minutes. So we can just see this trend towards point of care tests becoming faster and faster. Another presentation highlighting the need for rapid testing was this amazingly engaging presentation by Dr. Jabel Foster from James Cook University on the work up in the Torres Strait at the international border with PNG. People from PNG crossing the border for tuberculosis testing cannot be recalled for results and treatment. And this means that if patients don't receive their results, they would have to cross back over the border and they could be lost to follow up, making results and treatment difficult. Here, point of care testing using the GeneXpert, they were able to diagnose TB and also determine drug resistance, allowing for same-day referrals and treatment decisions. And this really transformed TB diagnosis in the Torres Strait. Another factor that the ideal point of care test must have is it should allow for self-sampling or self-testing. And so just here, I just want to draw a distinction between self-sampling and self-testing. So self-testing would involve an individual taking their own sample, performing the test and interpreting the results themselves. And these include things like home tests or over-the-counter tests. But self-sampling would include an individual collecting their own sample, but the testing is then performed by a trained professional. And both have their pros and cons. Self-testing provides the utmost privacy, but often self-tests have lower performance compared to tests that involve an instrument or reader, which self-sampling can utilize. And with self-testing, we lose the ability for disease monitoring as the result is not recorded. And both options came up multiple times throughout POC25, and I'll touch on a few here. So the first example was a presentation by Brittany Choate from Saliva Direct. Saliva Direct is a not-for-profit that spun out of Yale, and it's focused on developing tests using saliva as the sample type. And they chose saliva because it's non-invasive, self-collected. DNA and RNA extraction is not always needed, which simplifies workflows. It's cost-effective because it doesn't require sample collection buffers. Saliva is stable, and it's also a very versatile sample type. Following COVID, they did a study where they asked people globally, I think it was 125 countries, their preference for sample collection type. And you can see that globally there is a preference for saliva over other sample types. So they've been able to use this approach mainly for COVID testing, although they are expanding their assay menu in a range of formats, including the lab in the van, and also these vending machines on the right here, which provide anonymous 24/7 testing kits with self-collected saliva samples, which are returned into the vending machine for testing, and then results are then sent via whatever the user's preferred mode of contact. And they found this very useful for reaching rural communities. And I had a chance to talk to Brittany at the conference, and it seems that Saliva Direct is very keen for collaborators. So I've included their website on the bottom of the slide if people are interested, and they have a lot of information on their website. Another example for where self-sampling or self-testing is required, and there were actually quite a few presentations that touched on this, but here I'm just highlighting Raina and Ataya's presentations, which describe the importance of self-sampling and self-testing for transgender people who may be reluctant to have health professional collected samples. And they both shared really insightful stories of patients being reluctant to accept testing until it was in an appropriate format, showing that here self-sampling is actually essential in providing diagnostics to these groups. And the last example of self-testing was this self-testing device developed by Atomo with a built-in lancet and buffer delivery system. And this is good because people generally really don't like finger pricks. So making it as streamlined as possible is definitely ideal. And there were actually 3 presentations that touched on this Atomo self-testing device. So we had Elsie Williams from the Burnett with a new syphilis self-test, and we had Bo Newman and David Lewis who presented on programs that utilize the Atomo HIV self-test, which is distributed either through the post or through vending machines, and reducing the barriers to access for these tests, showing that it's vital and only possible through a self-testing format. So today I've only had time to touch on these 3 features of the ideal point of care test being portable, fast self-sampling or self-testing, but there were many more that came up at the conference: affordable, easy to use, satisfactory performance, which is normally benchmarked against laboratory performance, ability to determine drug resistance, and open source. I really enjoyed during one of the industry-led sessions, someone asked if they had plans to make their platform open source, to which they very politely but firmly replied no. But really an open source point of care platform would transform diagnostics in resource-constrained settings and for diseases which have few or no available diagnostics. And this seems like a really big list, and I mean, it's clear that there's still a lot of work to do, but I did want to end on a slightly lighter note, because I feel like sometimes when we look at how much more there is to do, we forget how far we've come. So using chlamydia and gonorrhea as an example, you can see how testing has evolved over the years. And even just in 2023, we had the VISB medical sexual health test, which is an instrument-free home test. And I just think this is a really exciting space to be in. And I'm really excited for what we'll be seeing in the future. And a big thank you to the AMR Hub and RAPID for the scholarship to attend the conference, and the conference organisers, ASHM, and the executive committee. Thanks.
Thanks so much, Louise. That was such a fantastic synopsis of the core principles of the ideal point of care test. It's my pleasure to introduce Miss Akriti Sharma, who is a data scientist at the Surveillance and Evaluation Research Program, the Kirby.
Good afternoon. I want to share my observations from two fascinating presentations I attended during POC25. While seemingly different, they revealed critical insights about the future of point-of-care testing. I'll be presenting my observations from a data analysis point of view. These two presentations approached infectious disease testing from a completely different angles. One was mathematical, other molecular, but their conclusions were remarkably aligned. Dr. Jerry Coast presented mathematical design specifications for infectious disease tests, focusing on COVID testing performance, while the other presentation, NG-STAR team, presented a sophisticated molecular typing system for tracking gonorrhea resistance. What struck me most was how both presentations highlighted fundamental problems with current approaches of point-of-care testing. Let me start with what both speakers identified as the core problem. First, with the Dr. Coast presentation, he opened up with a vivid example that really caught my attention. During COVID pandemic in USA, you could get COVID tests from ATMs without any oversight, no counseling, no quality control. And the big question was, is it reliable? His data showed huge variations in test performance, with the asymptomatic patients showing much worse result. And the FDA's response at the time required 3 tests over 5 days and labeled negative results as presumptive. This led to confusion and delayed diagnosis. This steered Dr. Coast to develop a mathematical framework that I found really compelling. Here's where Dr. Coast's presentation became really interesting from a data analysis perspective. Imagine a threshold. When disease prevalence crosses this line, your test starts missing too many cases. So if there are a lot of testing going around and number of cases are increasing, your prevalence is increasing, but at the same time, your test will give too many false negative. 95% sensitivity, 97% specificity. These aren't arbitrary numbers. They were mathematically derived by Dr. Coast. He worked on 33 original equations for this work, which represent genuinely new mathematical thinking about infectious disease. And I would like to quote Dr. Coast directly here. There's a mountain we just cannot climb if we start with an inferior test with very low sensitivity, even if repeated. While Dr. Coast approached this mathematically, the NG-STAR team took a completely different but equally rigorous approach. So the NG-STAR team presentation actually showed how sophisticated data analysis can transform infectious disease surveillance. They had 768 isolates, 139 sequence types, 7 genes. That's big data applied to microbiology. This wasn't a single lab study too. This was international collaboration with standardized methodology. And here's the remarkable finding. They could predict antibiotic resistance with over 90% accuracy just from genetic sequences. This means a clinician could know resistance patterns even before the treatment starts. Both approaches led to the same conclusion about what point-of-care testing should look like. Dr. Coase gave us a vision with what I think perfectly captures what both presentations were driving toward. A point-of-care testing should generate rapid, not delayed, actionable, not presumptive, and errorless, not repeated results. Both speakers acknowledged that COVID made point-of-care testing ubiquitous. People are using these tests everywhere now. But our current systems have conflicting standards, unreliable results, and waste time. The data-driven approaches from both presentations offer a path forward. What struck me most was how both presentations emphasized the same fundamental principle. Despite completely different methodologies, both presentations converged on the same critical point: mathematical modeling and molecular epidemiology. Different tools, same standards. Both speakers were adamant about manufacturer claims are not being enough. You need independent, multi-center validation. Both emphasized the need for standardized nomenclature and international collaboration. Whether it's Dr. Coase's tier classification or NG-STAR's reference strain quality control was paramount. This brings me to what I think are the key lessons for our field that I learned from Point of Care conference. Both presentations ended with the same urgent message. We need robust data systems, international databases, and predictive modeling capabilities. Mathematical frameworks like Dr. Koh's, combined with molecular surveillance like NG-STAR, could transform how we approach infectious disease testing. What impressed me most was how two completely different scientific approaches led to the same conclusion. We need higher standards, better data, and more rigorous validation. Thank you.
Thank you for that wonderful presentation, Akriti. What a sobering reminder of all the work that we need to still do. It's my pleasure now to introduce Dr. Kirsty Smith, Senior Research Officer from the Surveillance and Evaluation Research Program at the Kirby.
Thanks, Jessica. Thank you. Thanks for the opportunity to speak today. I'd also like to pay my respects to the Bidjigal people of the Eora Nation and the traditional custodians of all the lands on which we're living and working. I was asked to focus on the implementation of point-of-care diagnostics. So I'm just going to give a brief snapshot of a few of the really great presentations, and apologies, a little bit of overlap with Louise. So there were some really fantastic key population-led programs and services. This one, really spectacular example is the Tangerine Clinic, and Raina, who's on the right in this photo, presented. Raina's a great advocate for transgender people and was instrumental in establishing this clinic in Bangkok in Thailand. It's a one-stop shop for all health needs for transgender people. It's run by, with and for transgender people. And it was very much informed by consultation with the transgender community, who identified that gender-affirming care, mental health and sexual health were key priorities. Key population lay providers are very much central to service provision at the Tangerine Clinic. They conduct HIV pre and post-test counselling. They do fingerprint blood collection for HIV and syphilis point-of-care testing. They organise specimen collection for STI screening, and that's using self-collected samples for chlamydia and gonorrhea molecular point-of-care testing. They report test results, and they provide the initial PrEP, PEP, antiretroviral therapy and oral STI treatment as prescribed by a doctor. Some of the key outcomes that Raina presented were that there was increased access to STI and BBV screening and linkage to care for transgender people. 82% of people who are newly diagnosed with HIV at the Tangerine Clinic received same-day ART with follow-up with a doctor via telehealth. 57% of PrEP use in Thailand was initiated by key population-led services. And a quote from Raina, community-led research generates actionable evidence that drives real-world implementation and informs national policy and program design. And I guess a couple of examples of that were that they had noticed that there was increasing rates of hepatitis C among HIV positive MSM attending the clinic, and that's led to a new test and treat pathway for hepatitis C, also key population led. Another example was the research around acceptability of self-collected samples for transgender people that has led to that being the sort of the standard in the clinic. And the some of the delegates at the conference were invited to have a tour of the Tangerine Clinic, which I didn't go, but I heard was really fantastic. So that was really nice opportunity to actually have a look for themselves. Louise mentioned this talk, which was really fantastic example of Indigenous-led or an Indigenous-led program. This was looking at HPV point-of-care testing paired with cervical screening pathways in Aotearoa, New Zealand, presented by Jo Staunton from Victoria University. This work is led by Bev Lawton, who's the middle of the front row in the photo, and who, as Glenn said, that team from Aotearoa got together with our First Nations molecular point-of-care testing program, which was a really nice interaction. They, as Louise said, have a really fantastic mobile service using a truck which sort of goes out in all kinds of weather and difficult conditions to provide a service to rural women. They use self-collected samples, or selfies as they like to call them. And through access to, they use the Gene Expert for HPV point-of-care testing, which has led to reductions in time to colposcopy. And it was just noted that coordination with specialists is really critical to making that happen. And I guess that's been really useful for us in thinking through our HPV point-of-care test project, which is called PACE, which is led by Lisa Wapp. So some really helpful messages for us. Louise also mentioned this one, another really fantastic example of taking the diagnostics to the people with TB screening and treatment in Cebu in the Philippines, Samantha Tinze. And I might have to, I think it wasn't Gene Expert actually, as Louise pointed out, but they used the ultra-portable X-ray and molecular point-of-care testing to diagnose TB, and that has really dramatically increased case detection, as you can see in that not great photo. And a few of the messages Samantha gave, sort of key messages, were that digitisation, they used Starlink Roam, was critical for their supply chain and insurance claims. All the insurance money was put back into the program, and for tracking the testing and repeat testing. They use these pump boats to take the service to the people from a little island to another, and they provided a one-stop shop for testing and treatment, which really overcame some of those financial and other barriers for people who would otherwise have to attend city-based services. There was another great talk on neglected tropical diseases from Leanne Robinson at the Burnett Institute. She focused on malaria. I mean, some of the numbers, you know, are quite staggering in some of these settings. So she talked about, for malaria, 3.2 billion people at risk and 6 million cases per year in Southeast Asia and Western Pacific regions. So it's an enormous problem. Some of the common challenges that she noted were that you know, neglected tropical diseases tend to largely impact populations with very limited access to health services, diagnosis and treatment, and lack of accurate, reliable, affordable and fit for purpose point-of-care diagnostics. Early diagnosis and effective treatment of malaria prevents severe malaria and death. And currently, malaria rapid tests account for most, or 60 to 80% of all malaria diagnoses. However, a lot of cases are not detected by the current rapid tests because of dormancy, periods of dormancy in the infection, and different strains which are not picked up by current tests. So that they're actually working on a new test, but as noted, having an accurate and affordable test is not enough. Integration of new approaches requires careful consideration of the local context to maximise effectiveness. And there was really an emphasis on the importance of understanding the community and health systems perspectives to develop approaches that can be sustainably embedded within health systems. And of course, the importance of local ownership, leadership, coordination, sharing of resources, and a genuine partnership way of working, which is essential for the generation of evidence that will guide local implementation. So just a few quotes from the conference that stood out to me from Rainer. Ensuring affordable access to point-of-care testing technologies is critical to the delivery of timely, decentralised services where they are most needed, and that was really well demonstrated by the Tangerine Clinic. Nikita Pai from McGill University, co-designed with the person in mind, not the disease. And Joe Staunton from the HPV project in New Zealand, point-of-care testing facilitated community capacity, control, and resilience. And just finally, yes, a big thank you to RAPID for supporting my attendance at POC25. It was a fantastic conference, and really look forward to the next one, whether it be 26 or 27. Thank you.
Thanks so much for that fantastic presentation, Kirsty. It's great to see the sort of overview of the breadth of content and also of community involvement that was covered during the content. Now, last but definitely not least, we have Dr. Anna Conway, Research Associate, Viral Hepatitis Clinical Research Program from the Kirby. Thanks, Anna.
Thanks. So I'm going to talk a bit around the policy aspects and a bit of social science as well from the conference. So yeah, there was a lot of presenters touching on policy, but I'm just going to focus on 3 themes around testing for multiple diseases and pathways to integration, and the funding environment, and then self-testing. So first, in testing for multiple diseases, this slide was provided by the Clinton Health Access Initiative, who presented on the systemic challenges to integration. And they highlighted a few key successes, like the national diagnostic strategies that had been established in different countries, donor support, which aligned the country priorities, and then some challenges like fragmented financing limits, limiting the unified point-of-care testing policies, and weak primary health care in some countries. Chai was also emphasizing the importance of having machines, resources, labs, supply chains, IT systems, and other resources which are disease agnostic instead of meeting the needs of just one disease at the cost of others. And in this presentation, they were drawing on examples from Cambodia, where protein expert machines were owned by the TB program, making it difficult to use those machines for testing for other diseases. So after this presentation, there was interesting discussion off the back of that around the tensions between ring fencing funding for specific diseases and protecting that the testing for that specific disease, and while at the same time supporting integrated testing across diseases. And then some of the presentations discussed community organizations as key settings to deliver integrated testing, especially when they offer testing for multiple diseases alongside healthcare. Provision by community organizations are particularly vulnerable to the fragile political context, such as this example from Thailand, which Dr. Natalia was providing, who showed that this community organizations were testing for multiple diseases and delivering PrEP at the same time, and were approved through legislation from a government in 2019 to deliver PrEP. And the same government then revoked that legislation in 2023. And that kind of political shift can impact people's access to point of care testing. So thinking around the wider holistic access to healthcare. Then moving on to the funding environment, some of us from the Kirby Institute were talking about the Australian funding mechanisms for point of care tests. Louise Chow presented on molecular point of care testing for STIs, which is now Medicare rateable in remote areas, but not regional areas, presenting a barrier to access. And then in my presentation on policymaker views on sustainability of Hep C point of care testing, Medicare rebates were seen as policymakers as important for the financial sustainability of testing, but also to signal the value of point of care testing to providers. Then Rachel Devi from the Fiji Ministry of Health was discussing the role of funding mechanisms in the discovery of Fiji's HIV outbreak. So money from Global Fund was distributed to NGOs, which supported decentralized testing. And then some key organizations who were not registered, some key community organizations, if they weren't registered, that could be a barrier to rapidly delivering testing if the process for registration is complex. So really thinking around the legislative environment that can support community-based testing. And then self-testing and a little bit of self-sampling. And this slide was provided by Mohammed Shahid Jamil from the WHO, looking and WHO is talking about leveraging self-testing in light of widespread funding cuts. So the modeling here shows that facility-based self-testing can be cost-saving if the recommended WHO price is achieved. So there's lots of interesting discussion after this, especially thinking around if we move self-testing into facilities, then you're losing kind of what was the primary advantage of self-testing as being part of decentralized testing. And then there were other concerns about self-testing highlighted in discussions, such as particularly around introducing self-testing through multiplex testing and whether people were equipped to interpret those results. And then lastly, just thinking about acceptability of self-testing and self-sampling. And I thought this would be useful to highlight how dependent acceptability is on the population, setting, disease. And that all needs to be taken into account. So this is the first example from Thailand, which I think Louise was drawing on earlier. It speaks to the importance of self-sampling for trans women who might not want to have a healthcare provider take an anal swab, for example. And then the next example, a study from the Kirby among people who inject drugs in Australia found a large majority preferred staff-assisted antibody testing over self-testing. And in comparison, a study in an urban slum in northern India, excuse me, there was high acceptability for Hep C self-testing. So maybe in high resource settings, we should be thinking about preference over acceptability. Thank you very much.
Any burning questions that you'd like to ask? None in particular? I did actually have one. So I was wondering, as you've understood, there's uncertainty about what the next forum should be. So I was just wondering from each of your perspectives, if you could have a quick moment to reflect on something else you'd like to see that would improve, something that was missing from this conference, something that you'd like to see, any ideas that you have at all about ways to improve. If you don't have any, that's okay as well. I'm going to ask Kirsty because her face is large and looming on the screen. Sorry, Kirsty, but it is.
I must say,
is there anything you'd like to see?
I was feeling slightly overwhelmed by that.
Sorry, but it's okay. It's a small audience in the room here, so you're in with friends. Is there anything else that you think that you'd like to see at the next conference? Because we are sort of trying to figure out what the most helpful forum would be and what was missing, what we could improve upon.
Well, I suppose, I mean, I love seeing the breadth of new tests that are around and, you know, and seeing them up there on the screen. It's fantastic to see the progression of, as Louise showed that nicely, just that, you know, smaller, faster, cheaper. Yeah, I guess that's something that I find really interesting. It certainly was already in the conference, but more of that's always good.
Thanks, Kirsty. Louise, and just to recognise the irony of the fact that Louise is not here because of the results of a rapid point of care self-test taken yesterday. So appreciate you still being able to present online, Louise. Is there anything that you really would like to?
It was all really great, but I guess maybe some more forced networking. I missed out on the Speed Geek event because I was at another session. So maybe that would have filled that gap, but maybe some workshops or something to have a bit more conversations with people.
Yeah, I think that's actually some feedback we've got and something that we very much would like to include. So hopefully we can build that into the next next one. I'll just run through the others and then Lisa's got a question. Do you have any other, Aki or Anna or Glenn? You can come.
Hi. I definitely would like to see more from artificial intelligence perspective because, well, that's my background. And comparing to POC23 and POC25, there was some talk about AI, which was nice to see. And there were posters where people have mentioned how they're working using artificial intelligence. There were new tests, but there's a lot of work going on in diagnostics using AI. So that would be nice to see. Because that's a topic that everyone's talking about, and I think it's important to have that in the conference included since we are fresh and new. And that would be, if we are new, we are starting something, so why not include what's already
at the beginning, be there at the
Yes.
beginning. I think, and that's a really great reflection just coming from a separate conference around sexual health where they had a plenary on AI and there were digitization of diagnostics. It was sort of central to a lot of the conversations as well. Glenn, your thoughts?
Yeah, I think it's important to have community perspectives. So that was great. I guess the only thing would be to see, different community perspectives for the next one, really. So
Yeah.
yeah, I mean, we had New Zealand. It would be good to have like another, I guess, community from a different country as well. So yeah.
Yeah. And yeah, well, definitely that's a great suggestion. Anna, do you have any reflection?
Maybe just, well, especially for the next one then, thinking around with all the funding cuts that are happening and how that's really going to change the landscape of testing, and maybe being a bit more like challenging about the race to kind of cut costs with the delivery of testing.
So about like maximizing what we have, the efficiency of what we have.
Yeah, and what are the kind of challenges that might come up for communities whenever we're trying to maximize efficiency in that way.
Yeah, because it was front and it was mentioned. So, for example, Raina, who gave everyone loved Raina's presentation. She was just like really struck a chord with many people attending. Opened by saying 9 out of our 11 programs have just been axed, and every single organisation has been affected in some way. So that's a really great suggestion, Lise. And thank you for your support in all of this as well.
I hate a microphone. I guess I'm just going to sort of build on what you asked, and I'm curious because, we often go to conferences that are like disease specific focused. And so I find point of care so novel in that it's like all these different things coming together and you're kind of like, how am I going to relate to this person from over there that's talking about a totally different disease that I've possibly never even heard of? So I'm just curious on reflections on how you think that worked at the conference and how we could perhaps make that better at future conferences.
I don't know, Beck, do you have any thoughts on that yourself? I'm putting you in the spotlight here. Just, I think it's a really, it is, I agree with you, Lisa, it's a unique aspect, at least in my experience for this conference, and one that people really value. So it's sort of how to leverage that is what is the question. Beck, do you have any?
I mean, it's a good question. There's a few elements to it. I think firstly, it's how we entice people to come to the conference to begin with, because people are quite used to coming to their special disease. So we've done quite a lot of work with ASHM to really promote that integrated infectious disease model and a place you can come to and hear all about diagnostics. I think at the conference, we had progressed in regards to diseases, but it wasn't, there were some that were lacking or some that were a bit dominant. So I think that's something we can work on going forward. And I think that probably relates also to people who are on the executive and the committee and their interests. So there's a strong sexual health and hepatitis focus, but we probably need to stretch out more into the TB space. There was a bit of TB and cervical screening, but there could have been a bit more. There probably could have been a bit more on malaria. And then I guess for people to dive into those diseases, I think we need a bit more of the speaker type models, like workshops where you find a common theme that you can bring people together and talk through that theme which relates to all those diseases. And I think Louise Chow did that very well today, where she took 3 concepts and she streamed it across those diseases. And I think we could do that a little bit more, but perhaps in an interactive way. I got a lot of feedback about in a way, the conference was like a conference/workshop. And I think that provides an opportunity for point of care testing to actually bring people together in a workshop style format where they can share their experiences a bit more in a low key way. I heard that quite a lot actually coming through. I guess when the formal feedback comes and we can look through it in detail, there just perhaps some reflections to the point of that integrated disease. Yeah, thanks, Lise.
Thank you. And I think that's a really good point as well about that opportunity. Is even the name conference versus workshop as to what you're expecting to get that that interaction and feedback you're going to get. And it goes beyond the attendees. It also goes into how is this communicated, the benefits of this communicated to even the funders. So for example, the conversations when you're trying to raise money, which thanks to RAPID got across the line, and but it was a struggle, particularly in this current environment. You speak to, for example, people that you thought might have liked to sponsor it. They say, well, how many people are we going to reach? We normally only have, we've got an HIV test and you've got no GPs present. So actually, what's the value of us coming along in terms of our sales and our profits, etc. So I think it's all about understanding the point that you're making is where is this going? What do we need to do to improve the scale of point of care testing, which is of value to companies as well as it is to the people who are implementing and the people that are receiving. So, so I think are there a couple of questions online? Thanks for joining us, that's fantastic. So Geek Out session was great. I guess it's a sign that more interactive activity-based workshops and really engaging all the participants. So I think we're getting that, definitely that feedback from people, and perhaps is where we'll shape the next meeting. And from David, oh, hi, David. Was there any discussion of the incorporation of point of care and self-testing for surveillance activities? Example, monitoring the levels of influenza circulating. Thanks, knowing that you've got an interest in influenza surveillance, David. It's a really good question. We did have a number of presentations around the value. I think that was one thing that we tried to impress upon is it's not just an impact of point of care testing on the clinical outcomes for a single patient. It's sort of the value of point of care testing along the entire healthcare journey as such, all the way through to not just monitoring the trends in the incidence of infections, but also the conversations around monitoring resistance also at the point of care. So I can't remember a specific session, a speaker speaking to that, but there was definitely conversation around that as a critical important. I guess the key part for that then, David, is how making sure that all of those results are integrated, which Louise Chow spoke to very much around that notification systems and making sure that all the point of care platforms, if it's has some sort of digital connectivity associated with it to enable that. Otherwise, without that, the surveillance obviously is not possible. So, but yes, an important aspect. So I think, I'm not sure if there's any other questions. Oh, Virginia, please.
Thanks. Yeah, I just wanted to echo, I found this really helpful, hearing the sort of summaries across presentations. That was great. I guess for me, I think that the presentations and sessions that sort of dug deep into integration. So when I'm often talking to people at these meetings, I'm thinking about integration in a totally different way. Mm-hmm. I find out halfway through the conversation, the person's talking about integrating 3 tests into a cartridge. I mean, that's not what I'm thinking. You know, for example, we're seeing improvements in point of care testing for syphilis and HIV in some pregnant women, but actually less than a third of them in some low and middle income countries in our region are being linked to care then. So, I mean, that's a tragedy, one of many. And I think that kind of discussion around integration is really important. Then there's also governance issues. So for example, where we work in Indonesia, we have 4 different directorates that are involved in the testing of pregnant women using point of care tests. And they all have different ideas about who should be doing what, who's got responsibility for this, you know, and women in the private sector, providers can't actually enter some of their results from the point of care tests onto a national surveillance system that David was talking about. So those kind of integration, and I think Ari Prabhandari, a colleague of ours in her final plenary, really started to also kind of expose some of those issues for her work. So I'd love to see that. I think naturally it will probably morph more and more into these questions as the conference gets bigger and bigger.
Yeah.
Thank you.
Thanks, Virginia. It's a really important point, and it's interesting again as to when people come from different perspectives, what the terminology means. But that integration very much is has into the health systems. I agree that how at a bigger systems operations level we're able to maximize the value of those individual point of care tests. So I think that is something that perhaps even with our partners, that was something that was, for example, the Clinton Health Access Initiative. They're very much on the focus from a ministry as a health top-down approach in terms of what can the governments need, how do we access and make these integrated into the systems. Perhaps we can expand on those conversations in partnership with some of those organizations as well for the next conference. It's just one suggestion. So I think that's probably it. There's no other questions online. I really would like to thank all the speakers, also to Louise for bringing this together and wrangling the troops and getting everyone's momentum and convincing people to present. So thank you for representing all the scholarship awardees, and hopefully it was of value to all of those early mid-career researchers as well, and there'll be more opportunities to come. So thank you, everyone.